Welcome to the Sunday special on TopMedTalk. It's a potpourri of our favourite longer pieces, ideal for downloading and enjoying when you have a little bit more time. TopMedTalk. So I'm going to start with Simeon West. Simeon, tell us about yourself.
So I'm Simeon West. I'm one of the consultant anaesthetists at UCLH, and I've got an interest, nay, a passion in regional anaesthesia. I sit on the board of RA UK, and I very strongly believe in getting regional anaesthesia out to as many people as possible.
RA UK, is that the Royal Automobile Association?
It's not. I think if you Google it, it's got a few different societies. If you look, I think there's a badminton club somewhere there. But RA UK is the Regional Anaesthesia UK Society. We're the UK branch of ESRA.
ESRA, okay.
So ESRA is the European Society of Regional Anaesthesia, so it's the umbrella organisation for all the regional anaesthesia societies in Europe.
Okay, so one of our ambitions for this afternoon is to decode every TLA or FLA that we use to keep the abbreviations down so the whole world can understand what we're talking about. Sim, thank you very much indeed. Mark, tell us about yourself.
I'm Mark Harper. I'm a consultant anaesthetist in Brighton. I have a research interest. I have two main lines of research. One is in the prevention of perioperative hypothermia, and ironically the other one is the use of cold water adaptation for therapeutic purposes.
So cold water adaptation for therapeutic purposes. I've heard in passing you talk about this, and I think you do this sort of open water swimming when it's freezing cold, which sounds a bit crazy to me, but you're suggesting that's good for you, is that right?
In the right measure, I am suggesting it's good for you.
How cold and how long?
You can go as cold or as long as you want. Actually, the interesting thing is that hypothermia is always bad. So if you've gone too long and you get hypothermic, that's actually going to be bad for you.
Hang on. If hypothermia is always bad, how can it be good for you?
You don't get hypothermic. You stay in long enough that you adapt to the cold, adapt to the conditions, but you don't stay in too long that you become hypothermic.
So give us an example of where you might swim and for how long and wearing what to get this putative advantage.
You don't even need to swim with a pool. Mike Tipton, I work with down in Portsmouth, the Extreme Environments Lab, he's got a setup where he dunks you in a tank, and the classic dunking program is 6 dunks at 14 degrees, and you don't have to be in for very long. You just have to be in long enough that you bring your ventilation under control. That you can by the time you can hold your breath and control your breathing, that means that you have been in long enough.
I think I've seen some of that on the telly, but for the people who are thinking it might benefit their health, who enjoy swimming, what's the sort of accessible alternative?
In the UK, the accessible alternative is actually any open water. In Brighton, for example, in the summer, the temperature goes up to a maximum of around 20 degrees centigrade. And although you get more adaptation at a slightly lower temperature, at 20 degrees you still see maximal vasoconstriction. So it's having a significant effect on your physiology.
And how long might you swim for in open water to get a beneficial effect that you're suggesting?
I don't think you need to swim very long. As I say, just as long as you can get your breath under control, 5-10 minutes.
Okay, so what about just a daily dunking? Just get out there and sort of a bit of a refreshing get into the sea.
Absolutely. Yeah.
Now, this all sounds, well, one is, I've sort of noticed that people that go open water swimming look fit as a butcher's dog anyway. So has there any therapeutic benefit that you can separate from the fact that you're more likely to be quite active and fit if you do this?
We have, I can't say. It's not been separated out fully, and there are a lot of benefits. I always think of open water swimming as a kind of package of benefits. It's like being outside, which we know is independently is a benefit. It's exercise, which we know is good. It's a social activity. Well, it can be. Certainly the way I do it is. So you can't necessarily separate it out. However, there are people I know who have previously exercised, but have used it. As a good friend of mine, he's got inflammatory bowel disease, he's got Crohn's, and he has basically, for the last 6-7 years, he's entirely controlled his bowel symptoms through cold water swimming. So
you think, I mean, there's evidence, as I understand, from basic science that suggests that this is not crazy. You've had some hypotheses and others published in respectable journals, so it's not completely bonkers, this.
No, and there's good evidence. We've recently published a review in experimental physiology.
Yeah.
Looking at the potential benefits. So it was Kill or Cure was the headline title of it. And we certainly came down on the side of cure.
So do you think it's worth anyone who's got a condition that isn't quite coming under control to at least have a look at this and perhaps give it a go? Would that be a reasonable... You're not in any way suggesting it's a proven therapy. You're saying it's something that may turn out to be that could help some people?
Yeah, exactly so. And certainly the big thing for me, I think, what we're finding with all kinds of conditions is they're related to levels of inflammation. And the big thing for me about cold water adaptation is that it reduces your levels of inflammation.
Okay. Do you think that's anything to do with why people in Scandinavian countries and the cold belt tend to be a little bit healthier than those in more temperate or warm climates? Or no, too much overthinking that one?
It's possible. Although I did notice recently there was a summary of nutritional advice which says it's not just the Mediterranean diet, but it's the Nordic diet as well, which is rich in oily fish, is actually good for you as well. So it might have something to do with that as well. Okay,
so bringing it back to the clinical scenario, what we were discussing today, you were presenting, we were looking at some great technology that can help us to stop this happening, is around the time of surgery, it's easy to get cold.
Completely, yeah. It's easy to get cold. First, when you just come into hospital, because you become patients become very passive.
Yep.
And you're just sitting around, you're in an air-conditioned environment, you can get cold, and certainly peripheries can get cold very quickly.
And anyone who's been a patient or even been in for tests will know it's quite hard actually to get enough thermal things. Everyone else is thinking about themselves in the environment who's working there, and the patients are often stripped off and barefooted or whatever it is, and actually getting cold quite quickly, and that's not good for you, is it? You're not suggesting that's therapeutic.
That's not good for you. Again, you do not want to become hypothermic. You become cold. And the other problem with that, though, of course, is this business of core peripheral redistribution, because the majority of cold, why patients get cold really in the first 30 minutes after the induction of anaesthesia is redistribution of heat from a warm periphery, from a warm core to a cold periphery. So it all equilibrates throughout the body.
Okay, so I'm at normal temperature in the majority of my body in the centre, but the edges have cooled off. So once you put me off to sleep, my natural mechanisms get overridden, and all the stuff rushes out into periphery, so all of me cools down. Is that right? And
the issue is that if your core is warm, and so you're sitting there with like really cold legs and really cold feet. Yes. If your core is warm, you'll actually probably feel reasonably warm as well.
So therefore, I think part of what you're suggesting earlier is a lot of effort should be put into keeping people's peripheries warm before we put them off to sleep.
Yes, I think that's it, and that's the thing about pre-warming. So the total body heat content is maximal, I suppose.
So we've spent for the last, as long as I can remember, I suppose it started 15, 20 years ago, we put a lot of effort into warming people when they're asleep on the table. But we've probably lost a lot of ground by that stage. So you're suggesting bring that forwards, is that right?
I'm suggesting do both. Okay. I think we need to warm them when they're on the table as well. But to really make progress, we need to bring it forward as well. But that's logistically slightly more complicated.
And practically at the moment, how do you do that? Is it more complicated than duvets and blankets and...
It depends on at what stage your patient is at, really. If you get a duvet, if you insulate a patient, which is what a duvet would do, if you insulate them early enough and their periphery is nice and warm, that's absolutely fine. But by the time they've got cold, by the time the peripheries have got cold, by the time the total body heat has gone down, that will not be enough. You need to start putting active warming into the system. So
go back. So here I am. Let's skip over my age, size, and all that sort of thing. I've been in hospital in the last year or so. Arrive early, strip off, get one of those gowns that doesn't do up at the back, so your backside's sticking out. Have bare legs. Be told that something will happen to you in the next few hours. Stay in this bed space and remain a coiled spring, and you're gradually cooling. And that's fairly common, isn't it? I'm not exactly.
Yeah, fairly common. So very common. Too common.
So from the moment we do that, what should we be doing as an alternative?
I think there are two two approaches. One is you can put active warming, so active external warming, which is, I think the most practical way of doing that currently are these self-warming blankets. The Easy Warm is the most common one. And then you put one of these, you crack them open, some iron oxide reacts with the air and they generate heat. In a very specific reaction, it will generate heat to about 38, 40 degrees. You put that around you and that will give you active warming and insulation. So that's one way of doing it. The other, which probably a bit more controversial, but I think from our studies of cold water immersion is really the way that would be most effective, is to keep active. And keep active either by walking around or get on an exercise bike. I'd really like to put exercise bikes in pre-operative areas and get people to, if they want, just go on. Just go and spin it a few times. Maybe put a podcast up so they can listen to a MedTalk podcast while they're doing it.
My recollection is once you've got the gown that doesn't fit on and your legs are bare or anything, if you sit down, you sit in a chair that's cold and your feet are on a linoleum floor that's cold, and I'm fairly well insulated and quite robust, but even after an hour and a half of that going on, you're feeling pretty chilled off. Sim, is this familiar territory?
Absolutely. I think we've certainly identified this as a problem in my place. We're little steps, and we've started putting active warming on all of the beds in the anaesthetic rooms, underneath blankets, and then so the bear huggers have started there, and the patients are now waiting there underneath the bear huggers. They've got a nice warm blanket at the very least, and then if they're really cold, we leave the bear hugger going. But I think pre-warming the patients in a dedicated environment would be even better. We've got these sort of poncho type blankets, which it would be great for some of these patients to try and keep them warmed. And I think we all identify those patients who you're struggling to heat up on table because they've got so cold.
And when you say the bear hugger thing, you mean a forced air warming system? A forced
air warming system of some description that then is put underneath the blanket on the trolley. So for those
people who are listening who are not working in this environment, it's effectively, I don't want to undermine the excellent work that's gone into developing it, but it's like a big hairdryer blowing hot air into nicely controlled blankets that keeps everything warm.
Absolutely.
And that's mainstream of what we've done in the operating room for a long time, but now you're suggesting bringing it forward.
Yeah, bringing it forward one step so that we can bring that warming process as early as we can in the patient journey. And the other thing is obviously trying to keep the patients clothed for as long a period as possible, trying to predict the timing of the operations such that we can keep them as closed as possible for the majority of time, and then only get them changed just at that right time.
Does anyone from our audience here want to come in on that point and the practicalities relate to that at this stage? Anyone want to chip in on that? Everyone think it's a good idea in the audience? Anyone think it's a crazy idea, never going to happen where they work? Or it sounds to me sensible, as though we should put some effort into it. And I said the bit that people often don't or take their eye off the ball is that redistribution thing. They think the core is warm, they forget the rapid redistribution. When we're in the operating room, I think we're pretty good in many places at getting the forced air warming systems out, but there's a reluctance sometimes to warm the fluids until you get into bigger cases. What's your threshold for warming fluids, Sim?
Excuse me. So as a jobbing anaesthetist on that side, I have a couple of things available to me. I've either got a bunch of fluid in a warming cabinet, or I've got more active devices such as coil warming devices. And my personal rule of thumb is if I'm giving any more than a couple of litres, then I would pull out an active warming system. But I have no science to base that on.
Okay, Mark, where do you stand on that? What's your threshold for, or do you warm all fluids?
Don't warm all fluids. I think if you've got really short day case procedures, then with minimal blood loss, I'll give either not use fluids at all, which is one way of avoiding the problem, or stick to 500 mils. I'm a great fan of 500 mil bags. It's like really just kind of keeping a line open, being able to give drugs.
Do you keep them warm, your fluids, before you hang them, or do you think that's overrated? Because if you leave them in room temperature, they'll be 20 degrees Celsius if you're lucky. It's a big thermal sink a litre of fluid?
Well, a litre of fluid
degrees?
is about 0.2 degrees to your core temperature, thereabouts. I would love to have that opportunity. So I think that's the way. For short procedures, 1 litre infusions, I think sticking them in a warming cabinet and just taking them from there is the most kind of cost and environmentally effective way of doing it. Much more than that, then move on to active inline warming.
Okay, so bigger cases, we've got no doubt, active inline warming of fluids, some form of on-table warming, and any new tips for the post-operative period? Again, we tend to strip people off straight away, get them onto a cold trolley and wheel them out into a relatively cold environment. Anything we can do there to make things better?
Pre-warm them. Really, it's prevention is better than cure, and I think the pre-warming thing would be have the most impact on that. Immediately
post-operative, are you warming your trolleys and things like that? Because we tend to put them on a mixed sort of, a cold surface with cold bars on it, and it rapidly sucks.
Well, that's it. I think the technology we have that is best for probably best for doing that is, again, these self-warming blankets. They work really nice. You can just, if you're not using them intraoperatively, you just lay them on the bed. Yeah. And the things they're very robust. You can pull drapes off them and they don't rip. Yeah. So
simple measures.
It's simple measures, and then you can just keep that on the patient. And although they don't transfer heat as well as forced air warmer, they do transmit a significant amount of heat. And if you get them on early enough and you can keep them on afterwards, they can be really good.
Okay. Any bad news in this world at the moment? Any overwarming, overheating, infection issues?
As far as I know, there's no evidence that overwarming has created complications. However, I think it is possible, it is easy to do, and I think this is one of the underrated benefits of measuring temperature. Measuring temperature. In fact, you're more likely to act. We're assuming everyone is warming people as well as they can, and I think you're more likely to act on overwarming someone by turning the heating off than by underwarming them, because you're just doing everything you can anyway. So
last little bit on this particular subject area, where and how do you measure temperature? Because this has been controversial forever. Nose, pharynx, blood, bladder, ears.
Well, I think perioperatively, what you should be doing is as we put out in a nice guideline. You should be doing. You're not going to do direct measurements because you're not going to be putting pulmonary artery catheters in. So the next best thing is indirect measurements. So things like nasopharyngeal's good, sublingual's good. Zero flux is a new technology which can be used very easily in awake patients, and bladder temperatures as well.
And do you do core and peripheral? Or is that gone out of fashion? When I was a senior registrar back in the last century, that was quite popular to do T1 and T2.
I think core peripheral is intraoperatively is interesting information, but unlikely to change your management. Preoperatively, it might. If you've got big preoperative core peripheral gradient, that's a really strong indication to pre-warm that patient. And I think that's the way forward. That's how we need to be targeting our.
Can you do that with little the sort of things you stick on kids to measure that? Can you put a little colour indicator, sticky tape thing?
You could do, but you can just actually use those infrared thermometers.
Okay.
You have to put it on measurement mode, because they've got measurement mode, which is the temperature it's actually reading,
right,
and then they've got fudge factor mode, which is the temperature they think it might be.
Right. Okay, Sim?
I was going to ask, you mentioned earlier about thermal imaging cameras, and have you had any experience of those? And because they're coming down, they're cheaper in price, aren't they? You can get one. We've got one now that we're looking in to see whether we can be predictive about how successful our blocks are with the sympathetic block. We see that emerge very, very quickly. But they're relatively cheap devices that you can attach to your iPhone. Have you had much experience of those with warming?
I haven't. There's somewhere I've got a lot of ideas about how they could be useful, and the iPhone ones are great as a general thing, but I think what you need is something that is really accurate. And to get one, I have looked into this, to get one which is accurate to about 0.1 degree plus or minus, you have to pay sort of more like around £1,000, which is still actually, as you say, it's come down a lot in price, but I think that would be really useful to have a properly accurate one. I think when you're looking at blocks, you just need to see trends, and I think the iPhone cameras, which I've also looked at, are good enough. Yeah.
I've got a question from the floor.
Hi, I'm Dr. Sangtani from Queen's Hospital. Thank you for giving a very useful information for keeping the patients warm. My question is actually, traditionally we keep the theatre temperature quite low, and do you think if kind of the temperatures of theatres are kept a little bit high than traditionally, will that help in preventing the hypothermia in the intraoperative period?
Yes, it will help. Every little bit helps, and I do think that will help. The thing is, if you can minimise the time that the patient is exposed to that cold temperature, then by getting the forced air warmer or whatever warmer you're using on very quickly, it might not be that important, and the not having grumpy surgeons may outweigh any benefits you're going to get from actually keeping the temperature high. But it will make a difference, but with careful management of the other aspects, it shouldn't necessarily have a big impact.
Coming to the zero flux, for the first time I came to know about it. It is very interesting, and he also mentioned it is very reliable, as good as a core temperature. My question is, though it is a bit expensive, can't we start using one probe, starting from the preoperative, intraoperative, recovery, back to the ward? And instead of putting there, if you put on the chest or somewhere else, then it is the same probe which you are using, the same procedure. It will be very accurate.
Yeah, you can do that, and you can just keep it on. As long as you've got a reader, you can just go from reader to reader. It takes about 5-10 minutes to equilibrate, because it has to create that window of warmth through to the subcutaneous tissues. But you could absolutely do that. It would be no problem at all.
Sorry, so we didn't quite catch your name.
Bhanumurthy from South Wales.
Excellent.
I'm one of the consultants.
Excellent. Thank you very much indeed.
Hello, I'm Paul Hutchings, a consultant anaesthetist at the Norfolk and Norwich University Hospital in Norwich. I've got a more general question about facilities and resources for enhanced recovery after surgery. We are individually enthusiastic. We have 60 consultants. We have various packets of small areas of enhanced recovery that we've always done, but we're missing. We're losing momentum. I'm looking for ways to persuade our managers and service directors to help us to get more facilities. What sort of drivers are there to help us adopt more enhanced recovery after surgery facilities? Could it come from national bodies, or are there other sources? I heard some interesting information during our talk this morning for experience in the United States, where it's coming close to practice standard to have enhanced recovery.
So I'll start with that one. So from the point of view of motivators, I think the best way to get people remotivated is to do a simple audit of your drink, eat, mobilise within 24 hours. You can do it as a snap audit, and if you just go and visit every patient roughly 24 hours after surgery for a week, for example, you can send somebody out there with a piece of paper and a pencil if you don't have an electronic health record, and just count up how many of your patients are drinking, eating and mobilising within 24 hours. And if it's over 90% of the patients, then you're not going to make a huge impact with regards to what we do perioperatively to improve their outcome. What you'll probably find is it's nowhere near the 90%. And that is the thing to take to management and to turn around and say, the data suggests that if we're not achieving that goal, we're not achieving the length of stays and the outcomes that would allow us to save this trust hundreds of thousands of pounds per annum. So why don't we re-examine what's happened to our previous enhanced recovery programs? And at the same time, the Getting It Right First Time team, led by Professor Tim Briggs, orthopaedic surgeon from the Royal National Orthopaedic Hospital, is championing this at the moment. So if he is contacted and his team are contacted, including the anaesthesia leads joint appointed with the Royal College of Anaesthetists, they'll offer help to support you to get whatever you need within your organisation to get people to accept that if they're not hitting those high rates of drink, eat, mobilise, and they're not hitting those length of stays and they're not hitting those outcomes, there's an enormous amount of money left on the table, and there's probably worse patient outcomes associated with it. So that would be my opening gambit. Before I come back to the question, have you got anything to add to that, gentlemen?
So my focus of interest is obviously the regional anaesthesia side of things, and we've made big changes in UCLH by introducing a block room, and it was a struggle in the first instance in order to get funding for that. We went through the Health Foundation, which we're very pleased to get an award to try to demonstrate that it was a way of improving patient outcomes, and I think there's a good bit of work which Dr. Patel, who was talking earlier, has prepared for the Health Foundation in order to try and make that sort of thing scalable for individual trusts to try and show that improvement. So I think there are lots of bodies out there that extra to the standard budgets that we've got that we can try and tap into to try and get some of these things better for our patients.
I would say the stimulus from the perioperative warming perspective is a nice guideline. A nice guideline can be used as a stick to drive change and get organisations to comply.
Okay, yes, I would like to mention some of the things we have achieved where it just shows that it can be done. We have now invested money in a robotic laparoscopic prostate robot technique, which has driven that procedure down to 24-hour stay. But we're missing things like same-day major arthroplasty, where we were doing very well, got down from 5 days to 3 days stay, and now it's stalled, where I know from quality improvement for surgical teams meeting up in Northumbria, they're regularly doing one-day joint replacement work. If we have packet of procedures, we have a laparoscopic assisted nephrectomy is enhanced recovery, but if it's a partial nephrectomy, it's not. There are strange paradoxes. We need more facilities for preoperative assessment, technology for fluid management to optimise that. I just appreciate the help that you've given to find ways that we can get our managers on board for this, and the audit, I think, is a good start. Thank you.
And I think the key thing which the Getting It Right First team will help with is increasingly dashboards are going to be sent out with data for all of us to look at and be aware of. And it lets us have a clear understanding of the enormous amount of resource that we're leaving untapped. And most of that does relate to getting the patients, getting it right first time, getting them prepared and getting them out of hospital as quickly as is possible and getting them home and not readmitting them. And it's probably one of the few ways that we can free up a lot of resource and beds to keep the health system improving. Now, I know we had some more questions or comments. Here we go, sir.
I've got two questions. I'm Dr. Jitendra Garg from Queen's Hospital in Romford. First question, I do an orthopedic list, and most of the time when I'm trying my patients to convince for regional, most of them say with the word go, epidural spinal, no. So how to convince these people? Have you got any techniques where you say, I think more than 60-70% of the patients are with the word go. They say, no, we do not want it, nothing in our back, please. And my second question is, I think when you were giving the lecture, you said about high-dose opioid. So I want to know what is the dose as a high dose. I'm presently using about 400 mics of diamorphine. Is there any other dose which you use for spinal?
Okay, so thanks for your question. I'll address those in turn. Convincing patients to have central neuraxial blocks. I think it's very easy once you've done it and they see the results and they wake up in recovery pain-free, they know they've made the right choice. So it's trying to get those patients to come back and advocate for that technique to the joint school and to the ways that you're pre-assessing the patients, so that they've got something to reference, patient videos and a consistent message coming through right the way from booking, orthopaedic clinic, right the way through to joint school and then pre-assessment as well, that it's the normal to have a spinal or epidural anaesthesia for your major joints. And then on the day, your job is that much easier because they already appreciate that that's going to be the technique of choice. There are obviously some patients that are still going to choose a general anaesthetic, and we don't want to take away agency from patients in any way. But I think, from a evidential base, there's absolutely no study out there that's ever proven that regional anaesthesia has a worse outcome than general anaesthetics. But there's certainly plenty of signal and noise to suggest that regional anaesthesia has a positive benefit on post-operative outcomes, especially respiratory and thromboembolic events post-operatively. Regional anaesthesia for central neuraxial block has a positive benefit, and that's been proven in large-scale database studies over in the States, and on a smaller scale over here. So I think that's my message, is always that this has all the added extras of great analgesia, and but also has some positive benefits. I guess the other aspect of it is what is it that the patients are dreading about the central neuraxial block, and it's usually, am I going to hear the surgery? Am I going to see something that I don't want to see? And actually, most patients who do stay awake, they find that the engagement with the surgeons and the ability to see what's being done is actually really helpful, because it's positive reinforcement that what they expected is going to happen is going to happen. It's much less worse than they thought it was going to be. But those who do have sedation, our modern techniques of sedation are such that we can keep a patient amnesic throughout theatre, and so we can reassure them that they're not going to remember anything from the surgery if that's the method that they choose. And actually, so second question. So dose of intrathecal morphine. I mentioned that there are pockets in the country who are doing higher dose intrathecal morphine. We have, as part of our cystectomy pathway at Westmoreland Street, we use a higher dose than standard of diamorphine, up to 1 milligram of intrathecal diamorphine. And but all of those patients are going to a high dependency unit, because as you start to go up in the doses, you will see some post-operative respiratory depression. Morphine obviously much greater than diamorphine, and so I think if you're going much more than 400 or 500 micrograms of diamorphine, you need to be putting them in a monitored environment. And certainly if you're considering using intravenous opiate on top of that, then you need to be in a monitored environment. But I don't think there's an evidence base out there yet. There is certainly pockets of people doing it, and I've heard of people using up to 1.5 milligrams of diamorphine intrathecally for colorectal surgery and the like. But I think the evidence needs to be there that that's a safe technique as an alternative to a regional block. And I think my personal feeling is that if you're looking to extend the analgesia of the intrathecal opiate, it's a great place to put it, but why not supplement that with a local anaesthetic block that then gives you that additional analgesia too?
My name is Vishal Patel. I'm a consultant anaesthetist in Cambridge. I've got two questions. The first one is there a hierarchy among the various elements of the enhanced recovery pathway? Are some elements more important than others? And the second question is for Mark. Is a nice cold shower a good enough substitute for cold adaptation?
So two great questions there. The hierarchy of enhanced recovery, which is a commonly asked question. Can you please tell me what is the secret sauce? What do I have to do and what do I not have to do? And that takes us right back, I think, to Professor Kellett's original 4 columns. You do have to put a lot of energy and effort in preparing the patient, managing expectations, mitigating as much potential harm as possible by addressing things like anemia, diabetes, exercise tolerance, lifestyle habits, etc. So that's a must-do thing. And as I said, also managing that expectations, i.e. we do want you to move straight away afterwards. We will be asking you to eat and drink straight away. It is going to hurt. We are going to give you pain relief to make you as comfortable, we don't try not to use the P word, as possible, to allow you to achieve the goal of mobilising, which is really important for you not to get complications. So that has to be done. Then the only other things that really have to be done is you have to do that drink, eat, mobilise. So you must get people drinking, eating immediately post-operatively. You must get them standing up and walking around within 24 hours. Pretty much everything else is negotiable. So although we are trying to be opioid sparing or opioid free, many people have very successful enhanced recovery programs that use a fairly traditional dose of opiates. Although some people feel very strongly about the constituents of the preoperative drink, some people have great enhanced recovery programs using water or lemonade. So almost everything else is negotiable. Everyone agrees the surgery should be as minimally invasive as possible. Everyone agrees you have to deliver a pain management regimen that minimises nausea and vomiting and facilitates the mobilisation. And everyone agrees you have to get the fluid management right. But to say it one last time, preparation and achieving the objectives of the drink, eat, mobilise, almost everything else is negotiable. But once you've agreed what your pathway is locally, you have to do it consistently in almost every patient. And the only deviation from the pathway to be successful should be because of patient need, not provider opinion. And then when you do deviate, you need to document it and communicate it to the patient, i.e., in your individual situation, it was not right, in my opinion, to give this drug. Therefore, I deviated in your best interest, and I've communicated that with you and the notes and the team. It's a long answer, but from the point of view of the reassurance about the secret sauce. Now we can go to the more interesting, but maybe not as practical question, which relates to, can a cold shower do the same thing?
The study has been done. And the answer is no, it's not as effective. And the reason for that is there are two elements to cold adaptation. One is the absolute temperature you go into, and the other is the rate of cooling. And if you, in a shower, although the temperature might be the same, the rate of cooling is less. So that's why it's less effective. So it will be effective, but it's not as effective as full-on immersion.
Banamuthi, one of the consultants from South Wales. Recently I was listening to one of the orthopedic surgeons, and he was suggesting the way forward is doing the knee replacements without tourniquet in ERAS pathway, and he strongly believes in that. And I haven't seen that. Do you have any experience about that?
Yes. So yeah, interesting question. We moved over to not using tourniquets with our total knee replacements a couple of years ago, and certainly, so we still put the tourniquet up just prior to cementing. So it's put on underneath the drapes. It's all sterile, and then but we only inflate it just prior to cementing, and then after cementing, the tourniquet comes back down. And I have to say, I think there is less pain as a result of that technique. You know, the vast majority of our patients are done under spinal anaesthetic, but regardless on that, the longer term pain it seems to be better. I don't have scientific data to back that observation up yet, but I do think it's a valid technique. The only thing I would with the one proviso is when the surgeons then go to use infiltrative anaesthesia at the end of the case without a tourniquet, got to be very careful. In a bloody field, there is adrenaline in that mixture. Sometimes you see some systemic effects from the adrenaline, so I think it's probably best to have the tourniquet up still then as well.
Well, saying that, I saw a talk from a Danish orthopaedic surgeon, and his take was he looked at a lot of myths surrounding orthopaedic surgery, and one of the ones that he busted very effectively was the fact that putting a tourniquet for knee replacements doesn't actually reduce blood loss. There's no
don't need it at all.
So theoretically, you don't need it at all yet, and they have more pain, as you say. The pain from the tourniquet is so significant.
Yeah, and also the release of the tourniquet as well, if you've had it for the entire case, is quite a significant ischemic hit.
Yes.
Hello, Paul Hutchings, consultant anaesthetist in Norwich. Another question. We have an increasing number of frail and elderly patients coming through our service. Is there evidence beginning to be seen that the choice of anaesthetic technique and indeed the adoption of enhanced recovery program can change the high instance that we're already seeing of post-operative cognitive decline?
So I think that is certainly an area of great research interest. My personal view is that we do see an increased risk of post-operative cognitive dysfunction in the elderly having hip replacements under general anaesthetic. But I think that's probably to do with blood pressure control rather than the methodology. My high horse is always do a spinal, because the spinals cause less hypotension than the general anaesthetics in most people's hands, especially if we drop the doses of the spinal anaesthetics, and that should have a knock-on effect on post-operative cognitive dysfunction. The other aspect of that is multiplicity of drugs for turning the patients to do the spinals as well, and I think the SNAP audit certainly showed some patients were getting 4 different sedative agents prior to having a spinal, and that can only be a bad thing. But I think the work isn't there to prove absolute causality.
So I think this is not my specialist area, but looking at the literature on a regular basis, the associations are getting clearer and clearer. Mm-hmm. There's less evidence at the moment from prospective randomised control trials, but when I hear enthusiasts talk about this, they've gone to all the trouble of risk rating somebody, they've identified that they're at high risk of having cognitive dysfunction post-operatively. The spinal is given, but it's the adjunct therapies that undo all of the opportunity.
Absolutely.
It's the little bit of benzodiazepine, it's the little hits of X, Y and Z.
Absolutely.
Which really, why did you sort of bother? Because now you've undone it all by giving all those meds. Is that fair?
Yeah, absolutely. So we have a protocol for all our hips, which involves having a fasciolaca block at least half an hour before they have the surgery, before they have the spinal, and I think that mitigates the need for the vast majority of adjuncts prior to turning. And then if we are to use something short acting like propofol, I think is the ideal agent for prior to turning. So it's pretty much gone before the end of the spinal, and then the spinal does all of your work. Once the spinal's in, that patient's likely to fall asleep anyway. They really don't need another sedative after that. So we've been driving that protocol forward over the last couple of years, and we've seen the adoption of the technique come right up. And I'm consistently getting my colleagues who suddenly find themselves on the trauma list going, "Okay, there's a protocol. I followed it. I was really surprised when it really worked," which is great to hear, because obviously it's all anecdotal. I take that as a point, but I think it's one of those things when you see it work, you suddenly become a bit more of a believer.
Great stuff. Well, thanks. Our time is up. Any final comments as we go? Mark, anything to take home?
Warm your patients. Warm them more, and warm them before they get cold.
Pre-warm them, warm them, keep them warm.
And use more than one technique to keep them warm intraoperatively.
But being cold can be good for you under some circumstances. Watch this space.
Being put into a cold water can be good for you, but actually being hypothermic is always bad.
Okay, gotcha. Sim,
my take-home message is: use some local anaesthetic in whatever way you feel safe and comfortable in doing it, but make sure local anaesthetic is part of your enhanced recovery protocols.
Okay, so thank you very much indeed for everyone for joining in. TopMedTalk.
Nate Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com, and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.